Yeah, welcome also from my side. So we have the pleasure to quickly give a really bit an overview on what we are doing and how we are linked with this afternoon. I have the pleasure, I'm Roland Seeger, to start. And I would like to start with two messages. One is what is robotics doing in healthcare, and is it easy to bring them into this field? And then the second one, why? So you know probably all these type of robots. They are fixing or they're producing our cars. Unfortunately, they're not fixing our cars. They are working in a very structured environment and they're doing an outstanding job. There is about 450,000 of these robots which are installed every year, about 30% meanwhile in China. And not because labor cost is very high, but because they do this job much better than humans. Now, we are looking mainly in the future to these type of robots. Hopefully they will once clean up your kitchen. So this would be probably a nice present for your partner for the next Christmas. Unfortunately, I have to tell you that this is not available today. And I'm personally convinced that this will take a very long time. But this is much more what we actually will see in a hospital. So it's not so easy to bring robots in hospitals. They can actually walk, they can actually get on feet again. They know typically where they are, they do localization mapping, but they cannot understand the world. And they can do a lot of other elements also not. And what is the key challenges for these type of robots? So they are in a multimodal environment where you have very diverse and complex tasks. So it's much more difficult to fix a car than to assemble a car. They have to deal with a lot of uncertainty, with partial knowledge. They have to also not only see but feel. And this is a very delicate task, how to interact with the environment. We have wonderful hands. We can actually feel all the contacts. We can really very precisely control something. Then they have intuitive interfaces to other humans. We just say, "Go and bring me a knife," and then they go. And robots cannot do this. So there is still a lot of elements to go. For example, the tactility shown in this example, where they actually use the tactility for a human with some injection, and then you can see all of a sudden you cannot do tasks which you typically easily do, like these matches. Now, this is some story that they will not appear in all our environment in the near future because it's very difficult. But still, we need automation in hospitals. I think the main element is aging society. We have less people which are taking care of more people which are at higher age. We have shortages in labor in general. We have also to control the costs. And robots can do in some jobs much more precise jobs. They can. There are less invasive, for example, if you can control. And we will see examples this afternoon. Hopefully, people can then faster recover with these tools, actually, and of course they can do a lot of background work. And this quickly summarize only what we are doing in the context of this project. We'll see then my colleagues also. So we have already mentioned this Harmony project, which is a consortium of industry partners, but also end user partners, hospitals, 5 universities and research organization. We can see all this across Europe. So we are nicely spread across Europe. Our goal is actually to have robots which first of all do the jobs which are not of interest for humans, which are probably tiring. So to bring, for example, stuff from the incoming flow to the different place where you bring food up to the people's room, or you handle different elements which have to be handled, like all the bioassembly, which has to be handled. And this is somewhat still structured environment, and there is probably the first environment where robots can do a job. So with this, I would like to give over to Salvador, and so he will present a little bit what they are doing and bring the whole thing in the context.
Thank you, Roland. So, sorry. So, hello, everybody. I'm Salvador Pané. I'm the co-director of the Multiscale Robotics Lab, together with Professor Bradley Nelson. At our lab, the mission of our lab is to realize magnetic micro nanorobotic technologies. Micro nanorobots are devices that have the ability to navigate through complex fluids environments using external magnetic fields. And these devices comprise in little tiny micro or nanostructures that can navigate untetheredly, wirelessly, like this little helix here targeting a single cell, or also medical instrumentation that can be magnetically navigated, for instance, catheters, endoscopes, and so on. And our main target is to use these magnetic micro nanorobotic technologies for minimally invasive therapies. This also includes not only the design of the medical instrumentation, but also the magnetic navigation systems that will allow the actuation of these devices. Of course, there are a lot of challenges for the translation of these technologies to the clinics, starting from biocompatibility issues, how much therapeutic cargo if we use these devices for targeted drug delivery, and also designing systems, magnetic navigation systems, which comply with all the requirements for operating at clinical settings. You will see more in detail in the projects what are these requirements and constraints that we are talking about. Today, there will be 3 EU-funded projects related to all of these challenges that we are trying to address in micro nanorobotics. We have an ENGIE project in which we design micro robots for intravascular treatments. Specifically, we are targeting a stroke. We have also the HOSmart Eye, which is we try to integrate the magnetic navigation systems in healthcare environments, and we also use AI to help in digitalizing and making these technologies also be operated with in telesurgery. And then we have Minigraph, in which we have magnetic navigation and catheters to assist the implantation of neural implants to monitor neurological disorders. I'm going to finish very quick. It is important in all these developments we are doing close contact with the stakeholders, and by stakeholders, I do not only mean industrial developers, but also end users, and this, of course, encompass medical practitioners and also patients. Patients also can be key in making these technologies a reality. There was already people in COVID reluctant to be implanted a vaccine because they thought they were implanted microchips. Imagine if you try to implant a robot into them. Anyways, this is an example of one of our projects and what are the stakeholders in which we are in contact with or we will be in contact with. They represent different sectors of the industry, industrial developers like Siemens, also pharma industry. We have also representation of hospitals as end users, but also patient organizations, but also very important in robotics, especially for healthcare applications, is to talk with insurance companies to see if they are going to pay the bills for these treatments, and if there are liabilities, who will be responsible for those. With this, I would like to pass my word to Peter. Thank you.
So also warm welcome from my side. So my name is Peter Wolf. I'm standing here for the DH Hero project, which is actually presented later in more detail by Andrea. And I'm also representing the Sensorimotor Systems Lab. And next to, there are other domains that can be supported by robotics. So not only what has been mentioned by Roland, so in terms of logistics or supporting healthcare professionals, we are more interested in rehabilitation robotics. So that is our connection to the hospital of the future or current ones. So therefore, we develop certain robotics that can assist your motor rehabilitation. And if you like, you can join us or me for the lab demo later to see this kind of robot, which we have in the ML building or in the same building next to it. Next to it, we are also interested not only in inpatients, but also in outpatients, so to say. So we are developing assistive devices that can be used at home. And there is another example shown here that will be also shown in the lab demo afterwards. So the MyoShirt assisting you in the activities of daily living. And together with the Competence Center of Rehabilitation Science and Engineering, Rehabilitation Engineering and Science here at ETH, we are in particular interested also in the other steps of rehabilitation towards a continuum of care, so to say. And what we also learned, and that was also mentioned by Salvatore beforehand, how important this is to involve all stakeholders from the beginning on when you want to translate your research or bring it to the market and to deploy robotics. So it's in our case, we started with focusing on the patients first. But in the last years, we have really learned that it is so important to consider the other stakeholders as well, like, for example, the payers or the reimbursement scheme, and also to consider from the beginning on the legal constraints. And for that, in Switzerland, together with the rest, we are relying on a huge network with different companies and also insurance companies or clinics. But, and there I close the loop to this event here, as we are also part of a new project. So it's so nice that during these projects, you learn so much about the other countries and how their, for example, reimbursement scheme works, or what is present there, and also the legal issues that you have there. Because I think this is so important when you have a small spin-off, that it can really enter the market across Europe. And there are a few differences still across Europe. So that was my short introduction here. And then I hand over to you, Karin, again.
Thank you very much for the introduction and setting the scene for our event. I would like to introduce now our next speaker, and I would like to welcome on stage Lionel Ott, who is a senior researcher at the Autonomous Systems Lab, and he's actually working on mobile manipulation and learning environment representations. He joined ETH about 2 years ago, after he actually worked for the University of Sydney. And we're actually close colleagues because we are both in the Harmony project, and but he's the one who knows everything from the technical side. So welcome, Lionel, and please go ahead with your presentation.
Thank you, Katrin. Yeah, so Roland already said a few words about what Harmony is, so I'll expand on that a bit in like how the kind of whole idea came to be. And so essentially it's going to be about like, what do we see hospitals to be like in fiction? So if you look at any sci-fi movie, what we see is these nice, clean rooms. Typically, for some reason, always it's some sort of a bed that you lie on, and then magically all of your issues get fixed. And so clearly, I mean, some of the things that Salvatore showed might be something that eventually the writers are thinking of that could happen in behind the scenes there, but we're clearly not there yet. So where we are at the moment are more like, I think a lot of you probably know these kind of the Da Vinci robots, for which are also from other companies, similar things, but those typically tend to be really specialized devices, right, that aid a professional, say a surgeon, in doing a very specific task. So that's one kind of area where they used robots in a sense for people doing mobile robotics. They're not really the kind of robots we think of when we say robot. We probably think more of something what we see in the bottom, these kind of transportation robots that somehow drive around. And then the bottom right one, that's probably more of like segregated somewhere in the basement to do like hauling of goods and so on in a hospital. But then there's also some of those that are more kind of capable of moving between wards to transport goods from A to B to kind of serve as a courier almost. But essentially in all of those cases, there's still a human somewhere there that has to deal with the robot, interact with it, maybe load, unload it, etc. So that's a bit where Harmony comes in. Essentially, we want to add the ability manipulate into this whole thing. And so that's why mobile manipulation for healthcare comes up, where essentially the idea is that one of the tasks that oftentimes happens is that there's quite a lot of dull tasks that have to be done by somebody in a hospital, be that bringing something from A to B, or as we'll see later, unboxing things, because it needs a human and there's restrictions on what kind of background you need to be able to do certain things. But they're not really the tasks that those humans or employees could be doing. So the idea is to automate these tasks away, to free up the human resources to do the things that they would be much better qualified at doing. And as mentioned by Roland, it's a consortium made up of a bunch of universities, industrial partners, and end users, kind of informing each other on what is needed and what is possible, and then pushing what is possible at the moment. And so a typical example of one of the use cases, like you have this assembly line, there is essentially a conveyor belt with a lot of boxes that come in and they need to be unpacked and then moved somewhere else. So the robot goes there, opens this nice box, takes it, moves it over and places it on a table to then further be either put in a machine or maybe sorted or something. So that seems all kind of straightforward until you see what actually happens. So this is from the Karolinska Hospital where they actually doing this task. Do you want to play? Good. So this kind of task, so you have to remove a tag first to ensure that it's not been tampered with, open the box by interacting with the latch. Then happens to be a plastic bag, so you have to kind of open it, and then you end up with a bunch of trays in there with vials that need to be afterwards processed. So next step would be robot goes in, grabs them. So this seems kind of simple initially. So in 3 simple steps, you kind of cut a tag, open the entire box, and then you end up with, in most cases, hopefully something nicely arranged. In other cases, something that's a bit more messy. So to humans, that is like, this is super easy. We can do this all day long. Till you end up with something that looks maybe more like this as the tool with which you have to do this task, which is like, it's a highly precise instrument. It can move like probably more precise than we can move our hands without any kind of observations. But its end effector is this, let's say, somewhat clunky thing that's as wide as our usual hands. You have 2 fingers that are essentially wider than a thumb and kind of is nicely presented by Roland. They are anesthetized, so you have no feedback at all. You don't know how hard you're pressing on something. And you somehow need to get this into really tight openings. And that's one of the challenges that are faced when we want to be manipulation in these tasks that are made to be solved by humans. And you don't really want to change these because that would be then not scalable anymore. So from that, we get a whole list of challenges. So in the perception side, like we have to perceive that there is a rack with a lot of vials in it, then where you only see parts of it, how do you perceive this properly? The robot has to localize, it has to know to some quite precise degree where it is, because otherwise it might just decide to drop the one of these trays on the floor because it thought it wasn't close enough to the table to place it there, to navigate so that it can actually move around the space without annoying humans and constantly stopping and making abrupt motions. And then as kind of alluded to, the manipulation side of things. And that's only the kind of software aspect of things. And then the hardware side is even more challenging because we need to invent new ways of having end effectors that can manipulate and interact with the environment in a manner that's actually safe and feasible there, but also robust and fast enough that we can do these tasks in a meaningful time. So to close, so what does the future look like? So I don't really know what the far sci-fi future looks like for the hospitals and essentially healthcare, but I would say the shortish term future is more that we will see robots that are capable of performing these monotonous tasks, like mentioned here. Opening essentially boxes by trained essentially analysis is not really sensible, and that we can essentially be able to return these humans to do stuff on jobs that they were trained for, and that's why they chose the profession, so they can continue working on that, and then in that manner also address some of the essentially challenges that the health sector faces with, like there is just not many enough people that can do these tasks. And I think maybe as a closing word that there is always this perception between the reality of robots and the fiction of robots. And they oftentimes are much further apart than people realize between what we think a robot should be capable of, because we've seen nice videos in the media of a demonstration of what might be capable if you added 10 more steps to it, and how far we're away from actually being able to turn this into something that could be a product that would work reliably 24/7. And with that, done. Thanks.
Thank you. Thank you very much, Line. We actually have a few minutes for some questions. Anyone would like to ask a question to Line? I don't know, what was that? Isabella, did you just raise your hand or not? You didn't, okay. Who did? Okay, can you speak up, because is that possible?
I was just wondering if you can mention
Yeah, so the two industrial partners we have, one is ABB and the other one is ID Mind. And obviously, they're very different, right? One is an SME, the other one is like worldwide corporation. And we have essentially used different capabilities of theirs to see what can we do with that. And they also have obviously an interest in the future, maybe taking lessons learned together with the other publications that come out of the project to where to put and like what's the information that can be maybe then in the future inform product designs.
And Giulio, they're actually here because we had our project meeting. And can I just ask Pietro and Paolo,
They're
can you
kind of
just stand up,
down there.
please, or raise your hand? That would be great. So you can connect with them in the coffee break. Perfect. Okay, I saw a few more. The lady with the scarf.
I was wondering about the stability of these tasks. So what happens if you develop the whole thing and then the test tube company decides to change the size of their test tubes? And how often these things happen in like the actual environment that you have these changes that you need to react to? And how far does that affect then the robot?
So as for how often it changes like the whole actual sizing, I think that's probably for one of our essentially end users. But from my understanding, it does not change that often because it's like it would have to change many other aspects of the whole pipeline. But from the robotics side, like the challenge here is not necessarily that if the tube becomes 1.5 times as big or so, that wouldn't be the challenge. The challenge is really that they're stacked tightly, at least for the manipulation side, let's say stacked tightly within a constrained environment. That's like one challenge. And the other one for the perception side, if it's any of these learning approaches, yes, there might be a need to essentially relabel data, but the same method that worked on one of those should then also work on these changes.
Thank you for that. And the one with the blue shirt, please.
I think that's also partially depends on the essentially where this is being done. So some places they have more freedom. Is like in, for example, in Zurich, at the moment they're at a long process of revamping the hospital. So they're using part of this project also to get information on like what can you do. So getting informed for future decisions. But I think there is like these vials are typically processed by kind of bioassay machines that have like a standardized, let's say, they expect the vials to be given to it. And there is some automation already for that they get picked out and scanned and put in the system. But I think a human is still effectively quite faster in doing this task because we're just much more dexterous. But at times it can be that maybe it's something that doesn't need to be done really quickly. So you can farm it off to a robot that maybe does it at a quarter of the human speed, but you get to do something else meanwhile.
Okay, thank you for that. And again, a big applause
you.
to you.
And I actually have a little request because we have some people sitting on the stairs here, and I see a couple of actually empty places in between. Could I kindly ask you to move and let those people sit? That would be fantastic. Thank you. And there are also a few. I see two here. There's one here. So if anyone would like to sit. And we just have another one being freed here. That's great. Thank you. Okay, wonderful. Wow, then it's time for the next speaker. And I'm very happy to welcome Florian Hehmeyer. He's actually a PhD student at the moment at the ETH, and he's part of the Multiscale Robotics Lab, so basically the lab of Salvador. And he is, doing his PhD, as I said before, and he's actually focusing on the automation of minimally invasive procedures using remote magnetic navigation, and he will give us an introduction to the HoSmart AI project. Please welcome.
Thank you for the nice introduction. Yeah, also hello and welcome everybody from my side. Today I will give you an overview over the HoSmart AI project. The full title of the project is Hospital Smart Development Based on AI. And I will start with like a general overview of the project, and then I'll move on to like what we particularly here at ETH are working on. First, some general facts about the HoSmart AI project. The duration of the project is from January 2021 until May next year. And the funding of the project is approximately 10 million euros. And in total, there are 24 partners. So it's quite a big and complex project. You might wonder, what is HoSmart AI? And HoSmart AI basically refers to a platform that is being developed in the scope of this project. So the platform is meant for developers to deploy their solutions in the fields of robotics and AI. And those solutions can then be deployed on the platform, and hospitals have access to it and can deploy it in their hospitals to improve healthcare. And besides developing the platform, in the scope of the project, we are like basically developing the entire pipeline. So we develop the platform, but there are also 8 different technologies that are being developed and deployed on the platform. And then those technologies are tested in the scope of pilot studies in 8 different hospitals across Europe. Here you can see an overview over the pilot studies that are being conducted in the HoSmart AI project. On the right, you see a map, so it's really like all across Europe. And on the left, you can see in what fields those pilot studies take place. So it's basically pilot studies in very different fields of the patient journey, like all the way from logistics over treatment, surgery, to assistive care. And we also like tackle a couple of different diseases and conditions, just like cancer or cardiovascular diseases. And what I'll focus on in the second part of my presentation is the Pilot 4, which is what we are working on in the Multiscale Robotics Lab. And in this pilot study, we are developing, or we are facilitating remote magnetic navigation to treat cardiac arrhythmia. And we do this in collaboration with the hospital in Madrid. And first of all, I want to give you like just an idea of what remote magnetic navigation basically is. And in this short video, I'll just demonstrate that. So what you see here is basically just a catheter in simulation, which is located in front of a magnetic navigation system. And the catheter is just a hollow tube with a permanent magnet attached to the tip. And then by applying external magnetic fields with a magnetic navigation system, you can steer and control the movement of the tip of the catheter. And this is really all the concept of magnetic navigation. And this is what we are trying to facilitate to treat cardiac arrhythmia. And one very prominent type of cardiac arrhythmia is called atrial fibrillation. I'm sure most of you have heard of it. And atrial fibrillation basically refers to an irregular heartbeat in the left atrium. So the left atrium is what you see here. Okay, you can't see it. But yeah, the left atrium is what you basically can see where the blue circles and crosses are. And due to this irregular heartbeat in the atrial fibrillation condition, you have reduced blood flow and therefore also like an increased risk for stroke and heart attacks. And the irregular heartbeat basically comes from triggers or sources that produce electrical signals that then disturb the normal heart flow. So you have those sources which are located in the pulmonary veins. You can see them indicated with the blue crosses up there. They create those electrical signals and propagate through to the left atrium, and then you have this irregular heartbeat. And one very prominent or very common type of treatment is called catheter ablation. And in catheter ablation, you advance a catheter to the left atrium and then scar the tissue around the pulmonary veins to electrically isolate those triggers. And then by electrically isolating those triggers, you can restore and maintain a normal heartbeat. In the scope of our pilot study at HostSmart AI, we are developing solutions based on remote magnetic navigation. And then we want to compare those solutions to the current gold standard, which is manual navigation in the scope of an in vitro study. So on the right side, you can see a 3D printed heart model that we are using for our in vitro study. And there we basically surgeons can perform simulated ablation procedures. And and we are like developing one remote magnetic navigation approach in like a telesurgery setting for that, then one automated navigation approach, and both of those approaches will then be compared to manual navigation. And in our setup, we can collect different performance indicators such as procedure duration, contact stability, ablation angle, and also user satisfaction. And in this video, you just see like how our system works. So here you see like the 3D printed heart model that we're using, and we put a catheter inside, and using stereo tracking, we can track the catheter. So you basically have a very similar setup to the real setting. The surgeon can see the anatomy, can see the catheter located inside the anatomy, and then perform the ablation procedure. And this just allows the surgeon to do like some planning of the procedure. Then he can successively approach all of these ablation targets. And this is what we're using to simulate this ablation procedure. And we also like try this out in like a proof of concept study just for feasibility, where we try to use like a manual navigation approach that you see here in the bottom left. And then we also like did this with like just like a the video stopped with magnetic navigation. And one of the approaches that we want to develop and compare against the current gold standard is telesurgery. And telesurgery basically refers to a surgeon performing surgery remotely. So you would, for example, have a surgeon based in Madrid who can control our robot remotely here in Zurich. So we would do nothing but like sending like the controller to the surgeon. Then he can open his laptop, connect the controller, and then give input to the controller. And then via the internet, he would send like his control inputs to Zurich and thereby control the catheter. And then we create like a magnetic field, the catheter moves, and then we can track the whole progress on like on a monitor. And this is also what you see here in a video. This is just a telesurgery demo that we performed here within Zurich. So this is just like in an apartment in Zurich, and we are controlling our remote magnetic navigation system from there, and just trying to steer through the vasculature phantom that you see here on the bottom right. And it's actually working pretty well. And also the latency, which is like the delay between inputs and what you see in the graphical user interface, is only about like 170 milliseconds, which is considered to be, according to literature, almost real time for the surgeon. So it feels very natural. And to also give you an outlook of what will come and what we will work on, we also have like an automated navigation approach in which we basically try to fully automate this procedure. So the surgeon would only plan the procedure, pick like the ablation line around the pulmonary veins, then calculate and compute equally spaced ablation targets to get like a continuous ablation line. And then we can plan an ablation trajectory, and the robot will be able to follow that trajectory autonomously. So this is here you see it in simulation. We're like still working on bringing that to to the real system then, but this is just like to give you conceptually what we are like planning to do. And yeah, with this, I've already come to the end of my presentation. I would like to thank everybody who has been part of the HostSmart AI project from the whole consortium, and especially from the people in the multi-scale robotics lab. And if you have any questions, feel free to ask them now or to just send me an email. And yeah, thank you for your attention.
Thank you, Florian, for that. We still have about 2 minutes, so I guess 1 or 2 questions we could take from the audience. There's already one, so please go ahead.
Like for the manual navigation, where the surgeon just like rotates and translates the base. I mean, I don't think they use it so much because they often also have like force sensors at the tip, so they would just look at the screen and see how much force they're like exposing to the tissue and use that, rather than the feedback is more like for the actual navigation rather than like the ablation itself.
Okay. Super, thank you. Do we have another one? Yes, the lady first, and then you, please go ahead.
Pregnancy. Do you know more about it?
Actually, to be honest, that slide I copied from the consortium.
Don't worry, I was just wondering.
But I'm happy to share, like to find out and share the contact with you.
And last one.
I was wondering, I mean, reality, the art moves all the time and what such well. So how will your simulation take into consideration the fact that the target?
Yeah, no, that's a very good point. I mean, we're still at like in the early stage of the project. So right now we're trying to fix some factors, develop a solution that works in there, and then add complexity one after another. But that's for sure something on the list.
Okay, thank you very much. And thanks again to Florian. And we are moving on to the next speaker. And I'm actually quite happy that we also have a guest from Germany, not just from ETH today, but also from Germany. So we have with us Andrea Schwier, and she's actually coming from the German Aerospace Center, and is actually part of the DIH Hero project that Peter already mentioned. She's a innovation coach for that project, and she's also project manager for the Miro Innovation Lab. I don't know really what that is, but maybe you can explain a little bit. Yes, that would be great. And she actually graduated from Munich, and I think this is all what we need to know for the moment. And she will be with us the whole day, so you can also approach her during the networking break and for the apero. And thank you for actually coming.
Thank you very much for the introduction.
So welcome. So my name is Andrea Schwier. I'm working for the DIH Hero Network, and I'm an innovation coach. First of all, the DIH Hero project is a little bit different to the project we saw before. We are a kind of networking project, and what we are doing in this project is we are doing as well funding SMEs and other projects. So it's a little bit different. You will see what you see in my presentation are some examples we have funded, and these examples are already products that you can buy for us. So first of all, let's start. What is the DIH Hero network? Okay, so we are an independent platform which connects digital innovation hubs across Europe to create, at the end, a sustainable network. So what we are doing is, on one hand, really with funding, supporting small and medium-sized enterprises. We're trying to connect all the stakeholders, the business stakeholders, as well the healthcare stakeholders. We like to support the development of innovative products and services according to the needs of the healthcare system across Europe. We are as well engaged in this project in standardization for robotics in healthcare, which includes as well ethical, legal, and societal issues. The project is we are 17 core partners from 11 countries, and we have 16 DRHs currently. So what is our current work and activities? So let's start with this. So we already said, we are working as well on standards. We are collecting information on standards as well. Peter mentioned it, an interesting topic when you try to bring a product to a healthcare system. The reimbursement is a very important issue. We are collecting information on best practice as well. The deployment, what difficulties you were facing when you, for example, deploying a robot to a hospital. Another thing is there, all this knowledge is shared on one hand on our website, but as well on different webinars we are organizing. And one major event we have this year, the DHO Knowledge Conference, where we will share all the information we already collected, and as well as some insights from the project we have funded. We're developing as well, because as well a specific knowledge database, which gives you the opportunity to have access to all the information the network already has collected, and will collect afterwards as well. So, currently we have a couple of information we already have online, like for example, there's a repository regarding software libraries, especially which you can use in healthcare robotics. Then we have a safety guide when you're trying to develop a robotic system, what you can try out this tool. And we have as well, when we're talking about using user studies, are working with patient, a kind of ethic guides as a tool, which is available on our website. As well, we already started to try to connect more all the stakeholders, all the companies that offering specific service for healthcare robotics. So there is a service portal where companies can search for a specific service and contact the companies. And another thing is our standard portal, where we collect all the information on standards that are necessary when we're talking about building a robotic system for healthcare. One thing I already mentioned is that we are offering financial support to third parties. So what we organized 6 calls to fund different kind of projects for healthcare robotics. The aim of this is just because if you're starting to build robots for healthcare, it's not that easy way. So we want to accelerate the innovation in robotics, especially for healthcare. And on the other hand, you can't build a robot on your own or a robotic system on your own as well. Support the collaboration across Europe. So it's across European projects, and all the projects will be funded cross borders. So it's not just one partner, mostly it's 2 partners, and they're coming from different European regions. As already mentioned, we organized 6 calls and have funded 65 projects in these projects already. So one thing we have specific is for our projects, each project has its own innovation coach, like myself. So what I'm doing is I'm supporting, I'm be part of the project the whole time during the project is ongoing. So I'm the first contact if they have some problems. I'm open for discussion and as well from technical side, but I'm supporting on the other hand as well for some research issues, if it's So I talked already that we organized 6 calls. One call was an emergency call. We got a contact, the SC contact us in 2020 for open up a specific call for finding robotic solution support the current COVID situation. So we had to start to organize a call in less than 1 month, to organize the complete call, get the call online, review all the project application that we got. It was over 120 application for this call. And we, at the end, we choose 10 projects, which we funded for 100,000 euros. And the duration for each project was just 2 months. So the project, so all the products that we already saw should be on a very close to bring up something that you can test already in two months. So as well, each project got had an innovation coach. What you can see on the left side is a little bit where the most of these the application area where most of the application came from. So it's just an overview in which fields the application came from. So I wanted to give you one project which was funded, was a STERI project, and well, from the project, the company which was in lead to this was Metro Labs. It's a German company. They are coming from, they're building mobile platforms. And due to the short duration, of course, you need a system that's already running. So they came up with the idea to have an autonomous system for UVC disinfection. So the idea was to have an autonomous robot is going to the patient room when the room is cleaned up and then disinfect the room with the robot. So it's a very, the following video shows was record during the experimentation at the hospital. The one fact was as well, the company should show that they're working with the hospital or with the healthcare facility as well. So they were doing all the testing as well afterwards. And we said in the beginning, it maybe should take 8 weeks. At the end, it was 12 weeks because do some shortage, especially for the UVC things and for some mechanical parts. The production took a little bit longer. So at the end, the project was finished after 12 weeks. And the final product was sold, for example, to Decathlon. It's not a hospital, I have to say, unfortunately, not the healthcare end users, but they finally could bring the system totally to the market and could sell it to, for example, to Decathlon as well. Another thing, because was that there became more part in our work on standardization, because there were currently for UVC and the effectiveness of UVC, there were no standards available when we had this call. So it was a major issue for all the projects which were working with UVC, because there were no so much information, what kind of radiation to need to destroy really the virus in the beginning. So they work together with our standards as well on standardization regarding UVC robots. So another project I wanted to show, which was from the technology transfer experiment. This one is just to boost the transfer of innovative technology from only robotics more into the healthcare market. So when you have already a robotic arm or a robotic system, finding an application where you can use the system to support healthcare, the healthcare market. So we granted 10 projects with 200,000 euros. And one of the projects, which is already as a product on the market, is the Arthur system. What you can see here, the Arthur system is a product from the company Wobka, which is a Danish company, and they developed and tested during the project a robotic system that uses ultrasound to detect signs of early rheumatoid arthritis on hands and as well on the wrists. So the robot is doing this task autonomously. So there's no on the patient. So the duration of this project, because it was an experiment, was 12 months, of course. So because they developed everything from the start. They had the robotic system, but they had to develop all the other things that are necessary to have it on a platform. So the final product was Arthur, which I wanted to show here in this YouTube
Jeg synes,
video.
det er spændende, at man kan gå ind og trykke lidt på noget
Product,
teknologi, og så
video of the
kører der en
company.
scanner, så man kan se ledene, og hvad der sker i ledene.
Arthur-projektet, som er det her med at lave en robot, der kan scanne for os, den har enormt store perspektiver, fordi så har vi lige pludselig en ekspert, der kan lave ultralydsscanninger hele tiden, som ikke er afhængig af bemanding og erfaringsniveau blandt lægerne.
For mange tænker jeg, at der vil det give en væsentligt bedre forståelse af, hvad der egentlig sker, når man kan følge med på en scanning. Der er rigtig mange gode muligheder i at bruge robotterne.
Den bliver hele tiden bedre, end hvis man kigger på en uerfaren læge. Så er den jo meget bedre, og det er den hver gang. Så der er nogle store fordele i det.
So what you can see here now, the robot is scanning first, autonomously, and analyzing as well the data.
Kan måske blive sat i gang med en behandling eller forændret behandling, hvis det er det, der skal til.
Ofte er der ventelister til at komme ind på sygehuset, og vi kan kun vurdere ud fra, hvad praktiserende læge har skrevet til os. Hvis vi i stedet kunne have nogle flere data at arbejde med, så kunne vi måske rykke lidt rundt i, hvem ser vi først.
Det var en god oplevelse at blive scannet.
And this is already available. During this project, they already developed under medical standards to go fast ahead to bring the complete system to the product. And this year, they received the KUKA Innovation Award at the Medica for this project. So these were two examples, and I already mentioned it. We are collecting knowledge and we like to share the knowledge. So we have an upcoming event this year. It's a knowledge conference in Barcelona. And yeah, that's from my side. Thank you very much. Any questions? Impressive seeing those projects that you could support throughout the project and seeing that it's already available on the market. Wonderful. Looking at the time, we have time for one or two questions. For Andrea here, do you have any questions? You can ask me as well later on. Okay, well, thank you very much. And as I said before, you're still here, and it's also good to know that there's this upcoming conference. So I think this could be also of interest for us, for Harmony, our project, and we might see you there then. So thank you again, Andrea. You're welcome. And then we move on. My wonderful helper is called Fabian Landes, and he's also actually our next speaker. He also received his bachelor and master here at the ETH, and he's doing his PhD right now as well at the Multiscale Robotics Lab. And in between, he was actually doing his master's in Harvard. Very impressive. And he also worked in a semiconductor factory in Taiwan. So, and you're going to tell us about, if I remember correctly, about the ANGI project. So tell us, what is behind ANGI, apart from being the nickname of Angela Merkel? So the floor is yours.
Yeah, that was a poorly chosen acronym, I think. I get that a lot. All right. Yeah. Thanks for the kind introduction. I think I'll add tech support to my resume soon. So I was gonna start this presentation by telling you all how important robots are and how they all move into the hospital space. But I think this is probably not required anymore, because I think we all know we see more and more robots moving into the hospital space, and also especially into the surgery, into the operating theater. So this one is showing a Da Vinci robot, which is probably one of the most famous ones that we get. And this robot can essentially perform surgery, less invasive, but still open surgery on a patient. And it helps the doctor to get some more accuracy on the individual motions. And we've seen a lot of developments in these fields, but where we haven't really seen a lot of developments is in how we treat people with drugs. So there are certain ways that we use to get a drug into the system, into the human body, and almost all of them rely on some way of getting the drug into the bloodstream, right? Because the bloodstream is this awesome kind of highway that we have in our bodies that is naturally occurring there, and we can utilize this highway in order to distribute the drugs anywhere. So if you want to treat something in the brain, for example, you can just inject a drug into the bloodstream here, and it will naturally go, some of it will naturally go into the brain, and boom, we can do our treatment. This is very effective, and we've been doing this for a long time. But this way of treating diseases has big drawbacks, because most of the drug doesn't actually end up where you want it. It doesn't end up at your target site. But most of the drug ends up somewhere else in the body, right? We get a lot in the liver, for example, where it's metabolized. And all these drugs, especially the more aggressive ones, will then cause effects that you don't want. And we call these effects side effects. What we aim to do in the ANGI project is that we want to use micro-robotic platform that we are developing right now in order to bring the robots into the bloodstream and then locomote inside the bloodstream and release the drug at a specific target location for multiple drugs that we can use. And to understand a bit more about this, we have to look at these 2 decades, 3 decades of research that we already have in our field, in the field of microrobotics. So this field of moving small things at small scales is not new, and we've taken a long route and have come a long way. In our lab, we mostly focus on magnetic navigation, and I'm happy to discuss the reasons for this in the break, I guess. We also have a lot of research over the last 20 years in materials. So what kind of materials can we put into the human body? How does the body react to certain magnetic materials, and how can we actually get rid of them afterwards? We have a lot of work already being done on magnetic navigation system. I think Christoph will later present on the latest startup that has come out of our lab, Nanoflex Robotics, who now already commercialize the systems that allow us to generate these magnetic fields. And we've learned a lot about the fabrication of how we make our micro robots so that they are reliable, that they are repeatable. Looking at the field how it is right now, we still have some challenges that we need to overcome. And this is what we exactly want to do in the ANGI project. So we have to think about which materials can be used so that we still have a magnetic micro-robot, but still the body doesn't get harmed by it, and that we can get rid of the material inside the human body. We have to think about workspaces. So this might sound trivial, but if you look into the literature, a lot of really good systems only work with the workspace that is a few centimeters. And obviously this is something we cannot do in the hospital because a human is more than a few centimeters. We need to think about drugs, because loading a payload is probably, it sounds trivial, but especially with more complex drugs like protein drugs, we also have to think about their stability inside the human body so that we don't destroy them. And we finally have to start thinking about realistic flows and navigation conditions. So as an engineer, if you look into the kind of flows that you get inside the human body, it's really astounding. If you have flows in the order of 1 meter per second at the heart, that is really, really fast. And we have to tune our systems that we finally going to be able to do this. And in all these challenges is what we want to overcome on the ANGI project. And for ANGI, we have a very powerful consortium also across the whole European Union. And we have experts, for example, in the toxicology field who help us in the development of our magnetic materials. We have the University of Würzburg who help us to develop protein drugs that are a little more stable and a little more suitable for a system. And then, I think it's not enough time to mention all the partners, but we have a very strong team in order to do this. So what the condition we are first targeting in our projects are strokes. Strokes are the second leading cause of death and the third leading cause of disability worldwide. And it's estimated that somewhere in between 1 in 4 and 1 in 6 people will get a stroke. And I'm sure you're all familiar with what a stroke is. But a stroke is like if you have a blockage inside your brain's vasculature, and then this blockage then stops the blood flow to a certain region of your brain, and then you have sudden cell death there. And the big majority of these cases, you have a blood clot. And the state-of-the-art treatment of this is that we inject a drug into the entire bloodstream, which we call systemically. And this drug is called TPA. TPA is a protein, and it's really good at opening up all these clots. It's really good at opening up these fibrin meshes that make up these clots and that stabilize this occlusion that you have in your brain vessels. However, TPA also has a lot of side effects. Because it opens up all these little occlusions that you have, it opens up also, for example, you get all these swellings, you can get bleedings in the lung. You get a lot of side effects, which you don't care about when you have a stroke, because the stroke is much more important to treat in that moment. But that is essentially where we come in with the ANGI project and we say, wouldn't it be awesome if we can actually treat the clot where it is, if we can move there and open it up exactly at that location. So these are our goals. We want to transport a relevant amount, a therapeutic amount of our drug into the right target locations. We want to be able to control the rate of delivery, which is also important in certain diseases. We need to do this all in realistic volumes and realistic workspaces. We want to use compact systems that can actually be integrated into a hospital and into the operating theater. And we obviously need to comply with the regulations. I was hoping to be able to show some of our results. We actually have already finished the development of our platform, but we're currently going through the IP process. So I guess maybe in hopefully 30 days approximately, we can publish all our results. But essentially what we've done over the past 2 years is that we developed this drug delivery platform that can deliver the TPA inside a realistic model of the human brain. We looked a lot into magnetic optimization and how we can actually achieve this in large workspaces. And we also considered all the biocompatibility and biodegradability issues. In the end, now we were able to dissolve this blood clot or a model blood clot. Obviously, we don't have a real one, but we made a model one. And we were able to dissolve this blood clot with it's hard to say for German, with 5,000 times less of the RTPA than would be required in the systemic case. So we hope this will soon actually benefit patients. All right, that's all from me. If you're interested, I'll also be around later and then we can have a chat. Thank you.
Thank you, Fabian. I'm not quite sure, maybe I missed it, but what does ANGI stand for?
I can pull up the first slide. Can I?
I think we probably can. I think I
There you
missed.
go.
Ah,
That's
okay.
obvious, right?
Okay, so it's the abbreviation of a very long title.
I'm pretty sure we could have found another acronym for it.
Thank you very much, Fabian.
Yes,
Very
you're welcome.
impressive. Wow.
Thank you.
I mean, I've got a couple of films from the 80s, 90s popping into my head when I see that. Do we have actually any questions for Fabian?
Yes.
Please go ahead, Peter.
Sorry? So, they're controlled externally. So our goal is so if you want to have a realistic micro robot that you can use and you don't want to retract it, which is our goal, because we think if you have to take it back with all the flows and so on, there's a lot that can go wrong. We actually control them externally with the magnetic fields and also fluoroscopy. Yeah. Yeah. And then we are able to fully get rid of them afterwards. Yeah. So they are fully dissolvable in the human body. Yes, exactly. That's a really key aspect, right? Otherwise, you need to like maybe with a catheter go in and get it out again, and that's risky. Yes.
Okay, thank you. I think we have one more here, and then you with as well. C2, please.
So what's the mechanism for releasing the drugs?
I think I shouldn't comment on that yet, unfortunately. Yeah. It's we will soon have a publication on that, and then I was told so. I was hoping I can like show some cool videos of this as well, but we'll have it soon.
Okay, thank you. And then the gentleman over there, please.
Right now we are somewhere around a millimeter, and there are like certain So it's this term micro and nano robotics. It's a bit vague, but we have a few reasons for this. One is just simply the resolution limit of a traditional fluoroscope, right? You need to see what you're doing. And also there are fluid dynamic considerations for that. So there's a certain sweet spot where you are able to exert enough magnetic force and still are able to overcome the drag. Thanks.
And one more, Niels, please.
Yes. So yeah, exactly. So there's this term, right? Time is brain is the standard stroke term, right? If you have a stroke, you want to treat as quickly as you can. The bottleneck in stroke treatment in general is making sure what kind of stroke you have, because you can have an ischemic or a hemorrhagic stroke, and the hemorrhagic one is caused by bleeding. And then obviously you don't want to give RTPA because then you just make a bigger mess. And so that's pretty much the bottleneck. We can deploy these very, very quickly once you take the choice to deploy them. I think the biggest problem with stroke treatment is that you need to raise awareness. And we also have a lot about like dissemination in our project, because the signs of a stroke are very subtle, right? And then a lot of people put off going to the doctor for a day or so, and then it's too late for any treatment. Yeah.
Thank you,
Right.
Fabian,
Thank you.
for that.
Thanks.
We move on to the next speaker, last one before the coffee break. I'm very happy to have Sandra Wells with us here. If I'm not mistaken, you're from Spain. Oh, Catalonia, I should say. Yeah, I remember there's a huge difference.
The lucky
Exactly.
Salvador isn't here.
So Sandra actually graduated from the Polytechnic University in Catalonia, and she did actually 2 bachelors, very impressive, in physics, engineering, and mathematics. And she did her master's here with the ETH last year. She finished that one, and she was also part or doing her thesis at the Harvard Micro Robotics Lab, and now she's also a PhD candidate, and will give us some insights on the Minigraph project, and we're actually staying minimally invasive. So the floor is yours, Sandra, and everything is set up. Wonderful. Thank you.
Oh, but the screen isn't showing. Fabian. Hello, is it on? Yeah, okay. Thank you for the introduction. And I will be introducing a project that we're working on also at the Multiscale Robotics Lab, also at Nanoflex, which you will hear more about later, called Minigraph. And Minigraph started very recently, so in October 2022, and it's planned to last for about 4 years, well, exactly 4 years. And this means we are very close to the beginning of the project. So we do have an acronym, but the total title of the grant is very convoluted. I will try to break it down. So essentially, this project is for graphene-based implants that should be delivered through a minimally invasive implantation procedure, and which are whose goal is to perform neuromodulation to treat brain disorders. And specifically, the context in which they should treat brain disorders is deep brain stimulation, or DBS. And this is a surgical procedure in which electrodes are placed deep inside the brain. And through electrical impulses, target regions are stimulated, and this allows to treat several neurological disorders, like the ones that are listed here on the slide. Especially when these don't respond well to medication, then deep brain stimulation becomes a recommended option to some patients. And the main application is actually Parkinson's disease. So it's definitely the first goal of this project. And so right now, the way that DBS is performed is there's a metal rigid electrode that's placed into the brain. The implantation procedure is done manually with a rigid needle. And the deep brain stimulation strategy is open loop algorithms. So they don't really know what's going on in the brain. The algorithms are already preset. And through the MiniGraph grant or project, what we would change first is that the electrodes would be graphene based. So these would be flexible and miniaturized. This allows for a higher resolution recording and stimulation of brain signals, and then also a lower immune response from the patient's brain. And the patient in general. And then the implantation would be changed to robotic delivery with a magnetic carrier. We have a lot of magnetic actuation in the lab, as you've seen. And it would be steered, guided by X-ray. And the whole thing would provide a much more minimally invasive procedure. Then it would also provide higher location accessibility, so we could reach more regions in the brain and from more places. And then the electrode position would also be a lot more precise. And then for the DBS strategy, the plan is to have this be closed loop. So there's feedback from the brain that's being received. And then there are machine learning or artificial intelligence algorithms that are used for neuromodulation. And this allows, of course, continuous real-time monitoring of what's going on in the target region of the brain, and provides adaptive and personalized therapy to patients, which is really desirable. So to achieve all of this, there are several different objectives of this project. And the first one is to produce these graphene neural probes, as well as the ultra-thin implantable electronics that go on them. Then there will be more people working on integrating all of this and creating the fully integrated neural interfaces. And then once all this is done, what we also have to figure out the robotic implantation of this neural interface into the patient. And afterwards, there's also work to be done on creating this closed loop DBS procedure to close this whole goal. And different ones of our collaborators are working on each of these objectives. And as you can see, what we are going to be working on here at ETH Zurich and at Nanoflex is the robotic implantation procedure. So this is what I will focus on in the rest of the presentation. So the magnetic navigation system that we'll be using is the Navion, which you've already heard a lot about by now, and you will hear even more about later. And this is essentially a group of electromagnets that generates varying magnetic fields. And through this, you can guide soft surgical instruments in a very dexterous and safe way. And this can be applied to a broad range of minimally invasive surgeries. And another good thing about this is that it can be installed in a standard operating room, and it also provides appropriate accessibility to the patient. And so by now, this has been successfully demonstrated in a range of procedures: in vitro for endoscopes and gastroscopy, ex vivo for fetoscopes and fetal surgeries, in vivo neurovascular navigation in pig brain. And this video was shown before by Salvador, but something that is cool to see in this catheter navigation is that there's this retraction that's possible in a surgery. And this is a principle that can be directly translated to the surgeries that we want to do for deep brain stimulation, because if the target location in the brain is not reached correctly in the first time, the trajectory can be corrected. Whereas now with the rigid manual procedure, you need to restart the whole procedure with the rigid needle, which is a lot worse than what we could do with this. And so we also have in our lab some previous results on navigating magnetic needles inside soft brain tissue guided by electromagnets. And here's a very nice video of a flexible needle, magnetic needle, following a curved trajectory inside an ex vivo pig brain. And what's really interesting about being able to follow these curved trajectories is that in order to reach a specific target region, avoiding critical brain regions that you don't want to interfere with, we would get an increased number of incision points where we can start the procedure. And so in order to reach this goal of developing a new minimally invasive implantation procedure for these new implants, our first goal at ETH Nanoflex is to optimize and adapt the magnetic carrier to deploy at the target region these super thin cortical and subcortical probes using our electromagnetic navigation system. And then there's also the part of developing localization mapping and 3D path planning algorithms using the X-ray imaging that we have incorporated into the system. And last, validating this whole implantation procedure in vitro in brain tissue phantoms, and further down the line, eventually also in vivo. And so this is the team that we have at MSRL and at Nanoflex working on this. And this is also the list of our contributors working on the project. And that's all from my side. If you have any questions, please don't hesitate to ask.
Thank you very much, Sarah. I mean, if I'm just really looking at the future, I mean, I saw the controller of like the PlayStation there. So instead of having physical surgical instruments in their hands, so basically the surgeon of the future might actually train on the PlayStation.
A lot more fun.
Exactly. Okay, we have time for a few questions. So please go ahead. Well, it looks like you all want to go for coffee, huh? I think that's what it looks like. Anyway, thank you very much again, Sandra. And we also have you here for the rest of the day. So if there are any more questions, you can actually ask her also during the coffee break. So thank you again. Right. Okay. So you just got yourself another 5 minutes for the coffee break, which is great because we also have people online. I think it was we still have 54. We will head over 60. For those online, we will actually continue at 4:45. And then we've got more interesting cases. This one was about the research, but now we actually come to the companies and see what is like really available and can be sold. So we will have that. Just one more thing. If you hear this later on, not later on, but if you hear this while you still have your coffee, it's actually time to come back. The coffee break is in the other building in the glass. Welcome back. Okay, so we are ready for the second part of our event today. And we now have some practical insights from companies. And the first speaker, first of all, I would also like to welcome our online community. They're still with us, which is great. And it's also good to see still so many faces, and I hope you had a good coffee and networking break. So our next speaker, already prepared, is David Sargent. I hope I pronounced that correctly. Sargent, okay. He is actually currently the co-founder and CEO of Magnebotics, which is actually a spin-off of the Multiscale Robotic Systems Lab. Yeah, okay, perfect. And he's been actually associated with the lab since 2014 with Bradley Nelson, who's the head basically of this act. And actually, I don't want to go much further in there because I'm sure you will tell us a little bit more. And we are very eager to actually find out what Magnebotics is doing and what you're exploiting. The floor is yours, David.
Okay, thank you very much. Yes, I'm glad at least some of you made it back after the coffee break. So right, you've heard a lot about electromagnetic navigation systems, magnetism, robotics. We were actually clever enough to merge them both into one word with our company name. So magnetically as driven robotics, or Magnebotics. So we're a spin-off of the Multiscale Robotics Lab, as Catherine told you. We develop and market magnetic manipulation systems for high precision control of both small and large objects now. And our patented projects can drive groundbreaking research, enable unique processes in microrobotics, nanorobotics, biology, and medicine. Who we are, well, these are the three founders. Brad, many of you know personally or have seen his picture today. Simone was a grad student in Brad's group, postdoc for a short time. And she basically developed or refined the smallest of the three magnetic generators which we have. I came in as an outsider. I went through in physics, ended up in structural biology doing X-ray determination of protein structures. And in that aspect, we were needing to use protein crystals. Protein crystals are very fragile things. They're hard to make, but you nevertheless, out of the little droplet in which they grow, you have to harvest them, flash cool them generally to nitrogen temperatures and put them in the X-ray beam to do the X-ray diffraction studies. And this process of harvesting these fragile crystals is all still done by hand because it's so difficult to do. And I saw a demonstration of a mini robot which Brad's group had developed a little while ago. At that time, a little while ago, now about 10 years ago. And it seemed to me it was just the right kind of thing that we needed to harvest the protein crystals. And ultimately we founded Magnabotics and thought that would be a good way to start commercializing it. Turned out it wasn't a good way to start commercializing it, but we do a lot of other things as well. Again, often based on Simone Shirley's work. Subtitle here, Magnetic Magic for Medicine. We use magnetic manipulation because it works remotely. It can precisely control both a position, 3 dimensions of 3 degrees of freedom, and an orientation. The only orientation you can't control is around the magnetic axis of these devices. You can't induce a rotation but along the axis. So it's 5 degrees of freedom. And its magnetic fields are not harmful to biological material. So it's a very useful technique, especially for very small devices. So systems are used for the study of mechanobiology, for example, within a cell or the cell membrane, or tissues, the development of microsurgical procedures. You've seen a bit of them already today. I'll mention some more. The manipulation of delicate micro objects. These were the protein crystals I was talking about, and for targeted drug delivery. These are our products. The one on the left is the MFG100, the Minimag so-called. You can see it under a microscope here, under a normal upright microscope. The red dot there implies roughly the volume of in which you can apply this magnetic control. The one in the middle, the Octomag, was actually the granddaddy of all these. It was developed first in Brad's lab. It has a larger magnetic workspace, as we call it, with the larger circle here. And the latest one, the Navion, which you've seen, I didn't count them, probably a dozen times today already, which is used then for, the ultimate use of this is for real medical interventions. Which is handled by Nanoflex, which we'll be speaking next. We market the experimental version of it. So for non-clinical use, we sell the Navion as well. We've already sold one. So these are our devices, and I'll give you some examples of things you can do with them. The Minimag for cells, microfluidics, etc. We have on the left, the whole device. In red, you see the actual magnetic coil unit, which is the unit which uses the electrical currents through the 8 coils to produce the fields under a microscope. And on the left is the power supply and the monitor. On the right, you see the same device inverted on a higher magnification microscope, is often used for cell biology, for example. And I'll show you a couple of examples there. Here we see, let's see if I can make this work. Oh, it is running. It's not. Oh, there we go. Okay, maybe I'll restart it again. Here we've just defined various points. This is a 1/4 millimeter magnet in a dish, and we define a trajectory. If I can make it work. I can't. Okay, now it's going to go. We defined a trajectory with different spots, and it can be made to easily follow that trajectory. It's the kind of thing you saw showed before, right? You want to make a magnetic object move to a certain position, and this is the way it's done. In the middle, we see it's running already, that's good. We see a micro magnet now being guided around a tissue, a micro tissue held up on two posts. So this thing in the middle is actually suspended, and you can go around it from all sides. We'll see that in a moment here. It'll go down. On the right, out of focus, you can move it under this tissue, focus down onto it, so you can believe that it's really underneath there, and then move around to the side again. So this is a good example of the complete 3D freedom of motion of these things. You can't do the same thing, for example, with an atomic force microscope. There you have a lever which is attached to the lab. You can't suddenly do that with it. So here you have complete 3D freedom in space. And on the right side, if it will start again, we are actually now guiding a immunoglobulin coated magnet, not what I wanted, sorry. Still not going to work for me. Okay. Basically doing the same thing. Here we have a macrophage, and we're guiding a magnet around to it to actually engage one of the pseudopodia. I'll speak about that in more detail in the next slide. Here we see a slightly more detailed version of it. So on the top left, you see a macrophage with a real bacterium. Beneath it, we have a macrophage with one of our immunoglobulin-coated magnets. In the middle, we see, I don't know, is there a pointer? All right, top left in the middle. This is where we start. Our magnet is on the left, the macrophage diagonally in the middle. We've applied a magnetic field to hold the magnet in one orientation, namely perpendicular to the pseudopodia. And in that case, it simply is locked. You bring it up to the macrophage, it sticks to it, but the macrophage is unable to do anything about it as long as you're holding the magnet across the axis of the pseudopodium. It's released after about 20 minutes. Now it's very quickly reoriented by the bacterium along the axis, and in that position, it can be only in that position can it then be taken up. Very interesting possibilities for studying immune reaction, for example, right? So here you see the orientation on the right up until, so as long as you're having the field locked, it can't move. The immune cell can't do anything about it. You release the orientation, immune cell actively reorients it and is able to take it up. Interesting kind of study you can do very easily with this technique. Here we're using studying targeted drug delivery with a combination now of magnetic control and acoustic control. On the left, and I hope I'll be able to make this work, we see a bunch of nanoparticles in solution. They clump when you apply a magnetic field. And, sorry, is that a pointer? Great, thank you. They have clumped in the magnetic field, and if you make the magnetic field rotate, the whole clump rotates. If now, in addition, you apply an acoustic field, which at the right frequency will drive this clump to the wall. Yes. We don't have a mouse, right? Okay, what would happen here is you see the clump from here, then moving over. I don't even make that work now. All right, now there goes. So this clump would be driven to the wall by the acoustic force, and because it's rotating, it will translate. So it's just like a wheel on the road, right? This is now in a microchannel, and you can well have a flow of fluid. This could be a blood vessel, and because the fluid flow near the wall is relatively slow, this can actually be made to translate upstream. So you can translate up and downstream within the vascular system if you wish. So that's the combination of acoustics and magnetic field. Oh, there we go. Okay, driven to the wall and moving Here, there's not much of a background streaming, but it works upstream. The Octomag, which, as I said, was sort of the granddaddy of these things, and I've recognized what it does in so many of the talks already this morning. Here you see it on the left side with a rabbit's head in between the poles of the magnets, and this is being done for optical investigation. So on the right, neat thing is with an eye, of course, you can look through the pupil with the microscope, right? So you can visualize where your magnet is. On the right, you see a picture of a magnet. Still can't make this work. There we go. Within the eyeball, you can, for example, orient in one direction and suddenly snap the field like that. Study the elasticity of the vitreous humor within the eye. How fast does it reorient? You see there's an elastic region, a viscous region, and then the retarded elastic region. So you can do a lot of studies on the mechanobiology now of the vitreous fluid within the eye. Could be affected by a lot of things, you know, by diet, by health, by age. You might be able to do some interesting analyses with this. Here's another micromanipulation aspect. On the left, again, reminds us of various things we saw this morning, right? Here we're thinking of an eye model, like on the right here, with a catheter coming in with a magnet on the tip. So here we're going to be shooting now at a whole predetermined lattice of spots with a laser to reattach, for example, the retina. And that goes very nicely this way, you know, tuck, 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 tuck. Normally done by a physician, by a hand control. This can be done remotely. And on the right, I'll try my luck with this one. Again, within the eye, we have a small magnet about 3 millimeters long here, which can be then manipulated with the magnetic field. Nope. Nope. Okay. You would have seen it stand up, actually puncture that vein there. So you can you can orient it. You can apply a force, puncture it. If the tip were coated with a drug, for example, you could introduce a drug very locally there. And then using a magnetic field, you can retract it again. So it's a very nice application as well. Here we see the other thing, which you've seen many times this morning. I just want to mention that we are also involved with an Navion. It's called in our hands a Magnabotics Navion. It's not certified for medical interventions. It is, however, you know, for our purposes, it can be used for medical research or in large animals, for example, or in phantoms and this sort of thing. So whereas Nanoflex has the tough job of getting medical certification for it, and it will be a great application there. If you want to do some research before that's ready, you can buy one from us. All right. We like to think of this all as a touch of magic, where magic in our minds is magnetic actuation generates innovative concepts, okay? And brought to you by our great team of engineers and interns there in the picture, taken at the end of last year. We've grown from 3 founders and no employees to now we have 3 great engineers and several interns. And so we're really going up in the world. I'd like to thank now various sponsors and supporters of the ETH and MSRL to begin with. We've had a Swiss grant. We had an ERA grant for Parkinson's treatment, or actually it was for setting up an ex vivo analysis system for the effectiveness of drugs. And we're on the ANGI project as well. So we'd like to thank them all for their support. And what it's meant for us over the years since 2014, when we started, is finally we're on the rising curve now for our sales, gone up dramatically. And we'd like to invite you people to come aboard now as well. If you're interested in more details, please visit our website, www.magnabotics.com. So thank you very much. I hope I haven't overstayed my welcome. I'm finished.
Wonderful. Thank you, David. All good. Wonderful. Very impressive. Do we have questions from the audience? What you're doing?
You can give me your orders on the way out. Okay.
Very good
thank you.
point. But you're here as well for later on?
I'll be here. Yeah.
Okay, wonderful.
Hopefully for years.
Of course. So if you didn't dare, we have one question. Alex, please.
Out of what? Out of the eye? Well, that one is easy because I mean you're watching it with the microscope, right? And so you can guide it out just as well as you can guide it in. In other words, you inject it with a fine hypodermic needle. You can guide it back to the needle and just retract it that way. But I mean that's one very basic thing about magnetic control. You have to see what you're doing. It's like driving a car. You can't just close your eyes and expect to do the right thing. So you need some sort of positional feedback, be it with a microscope, be it with a fluoroscope in larger things, or also what was mentioned in a previous session with a magnetic localization apparatus where you don't need to visually see it, but you can detect its position with an array of magnetometer chips, which we are also intimately involved in. Right.
Thank you, David. Okay, while we're setting up the next presentation, let me quickly introduce our next two speakers. I'm very happy to have with us Christophe Choton. I hope, Choton, yeah, okay, sorry. Unfortunately, I didn't have French at school. And Alice Segato, you're both from Nanoflex Robotics, which is actually a spin-off of ETH. And Alice actually had her degrees from the Politecnico di Milano and also her PhD from there. And Christoph is actually the CTO and co-founder of Nanoflex Robotics. And I think you're based in the WUS Zurich. Yeah, so WUS Zurich, I mean, if you're interested of what they're doing, we've got Isabella with us. She's communications officer for the WUS Center. And there's also a couple of information over there, so you can approach her if you want to find out more about that. And we will have a look now at Nanoflex. So we're very eager, and the floor is yours. Thank you.
Thank you. Thank you for the invitation. So I think today we have seen some really amazing presentation on what we can do with magnetic navigation. I'm also coming from the same lab where we are getting all this presentation. I also did my PhD at the Multiscale Robotic Lab. And when I was presenting in conference the technology we are developing in MSRL, usually clinicians were asking me, when is that coming to the clinic? So to bring that to clinic is not so straightforward. From a research project to developing a system that we can use in a clinic into a patient, moving a catheter from the femoral artery up into the brain, it needs quite a lot of work, and it cannot be done in the context of ETH. So for that, we had to found a startup, Nanoflex Robotics. We try to commercialize the platform. We are helping navigating all this magnetic tool. So Nanoflex Robotics is a startup from the ETH that is basically developing this Navion platform for clinical use to help navigating magnetic tool. So we are currently building a team who is not only composed of researchers, but half of our team is coming from the Multiscale Robotic Lab. It's people who have done the PhD into this technology, but we also have added regulatory people, clinical affairs people, business people to be able to move that forward. So we have built a whole team of 15 people during the last year. We're currently working to moving this technology forward. With the great support of WUS Zurich, with a startup accelerator from the ETH, we have financed by this. So we are continuing growing our team. We will have 2 more people joining us beginning of May, and we're also looking for more people joining us. We have around 7 open positions that we will post into the next 6 months. So what we are really trying to do is bringing this magnetic navigation system to a clinical product. But you don't need only this magnetic navigation system. You only need to develop catheter. So we need to develop multiple medical devices to build a full portfolio of tools that clinicians can use. You also need to consider all what we need in terms of user interface, in terms of software for controlling it, for providing the full functionality. So we have also a full software team following all the regulation in place to be able to develop that. And also developing system for advancing the system, controlling it. So we are building basically a whole ecosystem around the Navion system. We will be clinically certified, working with clinicians, getting this feedback, their user need to push that forward. And it's a lot of work for us because we have seen this platform, all the amazing presentation we had before. There's a lot of potential application for which one we can use this platform. There's a lot of enthusiasm for clinicians. When they're seeing that, they're just asking, when can I use it in the clinic? Some of the clinicians I've been working with, they come, they test the system, and they question, oh, can I use it tomorrow? I have a special case. And you always have to disappoint them, saying it. The medical device regulation is quite complex, especially right now in Europe with the new MDR. So it's really a challenge. It may take 2 years when you are sending your documentation for review. We're just lying still until they open and start reading your abstracts. So it's not straightforward. So we will be focusing on first going probably to the US market due to the situation at the moment. And we also had to really select which application we want to go first. And for that, I will let Alice, one of our engineers, software engineer, presenting which will be the first application that we'll be targeting at Nanoflex.
Thank you, Christoph.
One time.
Is it green now? Yeah. Yeah. Can you try again?
Okay. Okay, this is working. Okay, so thank you, Christoph. So yes, these are all the potential application of our future clinical product, but let's come up with our first clinical application that is to provide a solution, a good solution for the treatment of stroke. So stroke is the leading cause of serious long-term disability, and annually there are over 13.7 million new strokes and over 106 million years of healthy life lost due to stroke, and 5.5 million people who died of stroke. Basically, during a stroke, in the 87% of the cases, you have a blood clot that blocks or narrows an artery leading to or in the brain. And the consequence is that there is the lack of blood flow or oxygen downstream to the clot. So the current clinical practice is to treat the stroke with injections, so intravenous injection of alteplase to fluidificate the blood and get the clot disgregated, but also to treat with the procedures such as the thrombectomies that consist of catheter that is guided through the blood vessels to the brain to remove the clot by aspiration, or with stent retrieval. And this procedure was proved to be better and superior with respect to the injection. And the key of this procedure is the time of reperfusion. So more your brain stays without, more the brain, not yours, I hope, stays without oxygen and blood, more hard the chance to get some brain deficit or even the brain death. So our first goal is to provide a clinical product and a robotic technology that can improve the navigation through tortuous vessels. So we started to test our first product in research in porcine model with the support of the interventional neurologist, the Professor Philippe Gruber from Arao Cantonal Hospital, where we tested basic functionality of the navigation and also the interaction of our robotic system with the Philips imaging system. And we were able to deploy and maneuver multiple catheter designs, and including magnetically rotated to advanced catheter, and we were able to deploy third-party stent retrievers provided by Medtronic, Strykers, and Microvention successfully through our system. We also tested our initial system with manual advancement, and we were able with our prototypes of a magnetic guide wire to navigate up to the middle central artery and the posterior central artery in a silicon phantom. So the key benefit of our magnetic robotic system is to provide a safer and perform a safer navigation with compliant magnetic tools and a faster navigation time as the magnetic field directly bends the tools into the desired shape. And in our platform, in our robotic system, we don't have moving part in the magnetic navigation system. And also using soft catheters and guide wires, we can actually reduce the complications. So as I said before, time is the most important factor in stroke reperfusion therapy. Every hour, a patient that with subject to a stroke, age 3.6 year, and with the possibility of losing functional independence every half an hour. So here we provided a timetable of the time that elapses between a patient that has a stroke to when he reaches the hospital and get the CT scan, get the stroke diagnosis. And then these times increase because maybe the hospital doesn't have the equipment or the interventional neurologist to treat the stroke. So there is also the time to transfer this patient from the general hospital to an equipped one. So together with our first objective, that is to provide a safer and a faster, this time, okay, a safer and a faster navigation. What we want to do is also competing against no alternative if no interventional radiology is present for thrombectomy. And we want to provide a remote platform, a remote robotic system. And in this way, we can allow teleoperation. And in this way, we can decrease the access disparity. And in this way, also the clinicians are exposed to Lexis X-ray, and they are working in a more comfortable environment. And in the most of the case, this brings also to a better outcome of the procedure. So based on this achievement, what we can do actually is reduce the time. So we can reduce the time because we can provide a better navigation, safer and faster navigation, and we can reduce the time because we can avoid to transfer the patient. We can, because our system, it is easily to be integrated in a standard operating room. The only requirements that we need is high voltage and water supply. And actually, we can connect a surgeon on the other side of the country to operate these patients in a generic hospital. So we want to leave you with the feedback that we received from our remote demos in the US. And all clinicians were interested in the demos. And they say that our platform was easy to use, was intuitive, and they were able to grasp the steering concept very quickly. And many could also be able to navigate the most difficult route. So what they said is that the big advantage, yes, for sure, they were on the other side of the country, and they were able to navigate the robotic system here at ATH. So this is a big achievement, but it was also that they were able finally to stay away from the vessel wall. That is for sure a great achievement for this treatment. So I want to leave you now with this sentence that is actually our system, because when a stroke happens, time is brain. And what we want to do is provide fast access to care to save brain.
Maybe this, yeah, it works again. Wonderful. Thank you very much to Christoph and Alice. Wow, I mean, I'm just overwhelmed, you know, also about the effects of not getting treated, you know, how severe it actually is. And I think the best strategy still is to avoid and live a healthy life. But sometimes you cannot choose, can you? You know, even if you might live a healthy life, there can be something in your body that can still cause a stroke. So very impressive what we can see here, and I'm sure you're exploiting it already, as far as I understood, and which is awesome. And we just have a few minutes for questions. So, do we have questions from the audience, or any comments on this very impressive technology? Yes, Eugen.
We are currently part of the verification validation phase, finalizing the design, and we hope to do first inpatient around September, October for navigation of the system in a clinic in Switzerland.
Okay. Any more questions for Alice and Christoph? Okay, then I think that's it for the moment. At least you're also still around for the apéro, so you can also voice your questions there. Thank you again very much, and
thank you for the invitation.
And of course, all the best and good luck with the growth of the company and making it happen. Thank you. Okay, so we come to our last presentation for today, and maybe you have already wondered what this thing is there in the corner. This is actually Leo, which has been developed by F&P Robotics. And I'm very happy to introduce Michael Früh, who is the CEO of F&P Robotics, and he's here with his colleague Nils Schläger. So what can I say about Michael? I mean, this is actually not a typical spin-off of ETH. Huh? It's like a ground company, which is also great. And you studied actually business and financial management, which is not really being in the field of coming from the field. But you are now building up a healthcare robotics unit at F&P Robotics. And you're also very eager to building partnerships with healthcare and research institutions like ETH. So I think this is a very good opportunity. And now I'm actually hand over to the two of them, and we're very eager to see what Leo can do.
Thanks a lot for the introduction, and hi to all of you. I'm happy to be here today to show you a little bit more about what we are doing at F&P Robotics, what our colleague, the robot Leo, can do, that you can see on the right side at the front, and that I can take you a little bit on the journey, what we do in assistive robotics. First of all, I feel our robot is really huge. After listening to all these micro robots, it appears I never imagined what a monster Leo actually is. But for our purposes, we need really a robot which can manipulate the environment, hand objects to people, etc. So F&P Robotics is active in two fields. So we do collaborative robotics, meaning automation of, for example, testing tasks of PCBs, bin picking, pick and place tasks. This is one business unit. And the other one is the healthcare robotics part, which I'm going to explain today a little more. So we are a team of an interdisciplinary education. So you heard that I'm having a business background, but I'm also trained electronics technician. So I have to say that as well. So a little bit technological knowledge I have. But we have psychologists, we have people with a nursing background, we have engineers like Niels from the technical side. We are a mixed team to bring those robots actually to life in healthcare environments. And we are here to help to solve some challenges we have in healthcare. So as you know, people become older, which is great, to new inventions, to new medicine, to like the companies that we heard before, to help to keep help people alive for as long as possible. But this also needs assistance, and it needs nurses, and it needs manpower and womanpower in these fields, and they are lacking. About 250,000 currently in Germany and Switzerland alone. And we think the robots can help and assist to create more time on the patients. So the robot we have created is called Leo. Leo is not an acronym or something, it's just a name, which is not so common for humans. We thought it's short and it's pronounceable in all kinds of languages. So here we are, and it has different tasks. On the left-hand side, you see the robot handing over a therapy ball to a patient in a rehab clinic for neuro rehabilitation. On the right-hand side, you see Leo transporting a box. So the purpose of Leo is multifunctional. It's not just a robot that does only one task. It's really dedicated and designed to do various tasks during the day. When you look at the environment of robots, so the x-axis is the more to the right, the more mobile and manipulation tasks the robot can do, the more up, the more learning algorithms are involved. So you have the social robots that are used for interactions with children, with elderly people, to make them feel better and have a social connection and interaction. You also have some medicine robots that help you keep the adherence, the medicine adherence that you take and do your therapy, you take your pills and do your therapy. You have many single task robots like cleaning, transport, etc. And then you have the robot assistants, which combine these aspects and really have a multi-purpose functionality in the field. I would like to show you a quick video where you can see Leo in action now here in a rehab clinic. So in the morning, Leo is dedicated to transport lab samples from 4 different wards to the entrance where the courier comes and takes it to the lab. So it goes to all wards. Leo can also distribute drinks. It's important to drink in elderly care homes, especially when it's hot. People need to stay hydrated. And with the arm, you can actually give the drink to a person sitting in a wheelchair, not having to reaching for it and so on. Leo can be connected to all kinds of different devices like an elevator, like also Bluetooth devices, etc. It can navigate autonomously using laser scanners mainly, but also 3D cameras for navigation, so people are safe around Leo, which is a key aspect, of course, in these clinics so that you don't injure anyone who is already injured or fragile. Leo can stop, of course, when someone exits the door. It also tries to show always what it does, whether it's needing to charge, which it can do autonomously, which it's on a delivery tasks, etc. Here you can see another application which was developed by in the DIH Hero project, by the way, which is disinfection of door handles with UVC lights. We created this new feature in 12 weeks. Here you can see it for night watch. In the night, Leo can patrol the floors and send the alert to the nurses on their phones when someone is on the hallway which should not be there. And then they can guide the gentleman back. With the arm, Leo has the possibility to open doors. At the moment, you're only using it to open it a little bit and give a reminder. You have in 20 minutes, you have an appointment, be ready, that people get ready on time. We don't actually drive through at the moment, but we are working on that. And Leo has many social skills, can tell you jokes, quizzes, tell the weather. Leo can be female or male, by the way. It's agnostic in a sense, but also have a social component is also important in elderly care homes to activate people and give some joy and quality of life. But there is also a business case behind it. So Leo has standard functions that you just have seen in the video, and they give work support on a daily basis. We add them up with social interactions to really spend time with people when there is no human around, having time to spend people to improve therapy, to improve quality of life. And there are many more functions we aim to develop in the future that can be added to Leo. So overall, Leo has 3.3 full-time equivalents of time during the year to actually work and help and support his human colleagues as a good assistant. And there Leo should, first of all, improve the quality of life of people around him. It should take some work away from the nurses, and it should improve hygiene and safety with patrolling, with disinfection tasks. We at the company, we developed the technology ourselves, so it's not a bought arm or a bought platform, so it's really our IP, the robot as a whole. We combine an OS, so an operating system which powers and controls the whole robot. It's also our own. We have algorithms we use for many things like detection of people, etc., taking decisions. And where is also a lot of know-how is in the cover. So please touch Leo before you leave. It's a soft robot which is designed to be safe and should invite you to touch it and not be afraid or scared of the robot. So in that lies also a lot of knowledge and IP. So what are we working on from a technological perspective? Because this is also a lot about R&D today. So we're working on the decision engine, which actually senses the environment and tries to project the next suitable action for the robot. So on the left side, the robot tries to figure out what does the human do? Is he sitting too much? Should he drink again? And then value that and then propose, okay, you should drink. So a proactive behavior is key for a robot to be actually valuable and to not only have only pre-programmed actions. And on the right-hand side, you can see the navigation part of it. Some of you might know it already, but this is, if it would start, it is showing the different sensors the robot has. Unfortunately, it's not loading, but it's not so important. But the robot drives around and using the 3D camera to avoid all kinds of obstacles, and also using the laser data to create the map autonomously and then orient itself within this map. What you can see here is also simulation that we are using. So if an elderly care home, a rehab clinic, a hospital is interested to have a Leo, we can build a simulated environment, and then we can already calculate how long does it take to go to different doors to do the task, how many things can a robot do on a given day, and then let it run on a computer, show it to the customer, also helping our people who go to install what they have to do and how it's done. Here you can see also an easy interface to execute some tasks on the robot. And I'm going to jump a little bit time-wise, but you can see the robot running just through the whole facility all day long, showing and calculating the time it needs, etc. Zoom quit unexpectedly. Should I wait, or do you want to log in? Okay, yeah, what you can see here is basically the robot doing a training fully on the machine without having to go out in the physical environment. So in this example, you see how the robot tries to grasp the door handle over and over again, tries different approaches, and then in the end figures out how to do it itself for a given handle, and then we can copy this algorithm on the robot, and the robot is capable of dealing with this door handle in the practice. So you don't have to do it physically, so you can train the robot by reinforcement learning on the machine, put it on the robot, and then actually execute it in practice. The other important aspect is also the user interaction and UX part of our development. So you can see here what we do often. So we go with the robot to elderly people. They should interact with the robot. They should try it out, what goes well, what goes wrong. And here you can see that the old, very nice lady needs to give a ball to the robot, and she tries her best, but she fails. And then the robot didn't recognize it in that particular situation. And then she instantly feels very bad. Oh no, sorry, robot, I did it wrong, and so on. So she felt really responsible for that. And that's and then she come back up and so on. And then we help her. So this just shows how people interact with the robot in a way you would never imagine, so that they feel bad. And so you have to address all that kind of things. We also use the robot at home for people with a disability. So this lady has is tetraplegie. Unfortunately, I don't know it in English, but just from the back downward, she cannot use her limbs, and the robot assists her at home, so she can remote control it. Also like Leo. Leo can also bring something to me, of course, by remote control. You can see my colleague can now steer the robot with a 3D mouse in that particular case. She, in the video, used her mobile phone, which she was used to use all day. But the input device is basically free. So you can have a wheelchair controller, maybe a teleoperation device you guys use for your business, could also steer the robot and then help in everyday tasks that you cannot do by yourself, and you always need human assistance. It's also good that you can be more independent and not use a human like a relative or so all day long. So if I'm thirsty and I don't have always Niels with me, but I could control Leo myself and then to get the drink when I want. Yeah. Right. So you can open it as well. Yeah, exactly. Yeah. So that you can do independently on all kind of steering devices. So it's also an individual support task the robot can do. Yes, so basically what we have to do is we have to bridge it from high tech, so below these nice surfaces, all kind of motors, machines, what you can imagine, cameras, etc. So we need to bridge the gap from science to make it very easy for the end user to understand and very easy to use the robot in everyday life. And this is a challenge, not a technical challenge mainly, but also to understand the user and then to transfer it to easy interfaces, etc. Yes, so this is already my last slide. So Leo is already active in many healthcare facilities in Germany and Switzerland. So it's a real life product. We produced 20. We are producing other 20s while I'm speaking. And yes, so we have a lot of experience what it takes to bring robots to healthcare facilities, how to integrate them, how to train people, and so on. We also have an R&D version of Leo where you can have access on different machines to also create your own applications, to create your own tasks for Leo. And we are very interested in R&D collaborations, as Katrin said, but also, of course, in end users who would like to go on the journey for robotics in assisting healthcare personnel. Also, I would like to make some advertisement for the Cybathlon, which takes place next year here in Zurich. And also there is a new category called robotic assistance. And also Leo would be a very good robot, which is already planned to be there to do the exercise and the Cybathlon and to fulfill these tasks. And if you're interested in that, that's also an interesting option. So let's keep in touch and thanks for the attention.
Wonderful, thank you. That's great. And I think we could actually open up because we're going to have some lab tours in a minute. And I think whoever is interested could also stay here and play a little bit around with Leo.
Sure, yeah.
Wonderful, that's great. Okay, do we have any questions for? Yes, please, Nikki.
So I think the robot can handle quite dynamic environments. So when obstacles are around, it can recognize them. But I'm not sure what kind of changes you mean. So for navigation, it can avoid things that stand in the floor or so. That's fully autonomous to drive around it. Also when people come, so that's no problem basically. Okay. If there is a way around, which is not much wider than, if Leo fits through around it somewhere, then it can do it. Yeah. Aha, yeah, okay. So the map consists of fixed items like walls and things like that and stairs, but there is also place for things that are there just without planning. And then the robot knows that they are not fixed and tries just to avoid them. So maybe I'm not really getting the question right. Maybe can. So the map is created once, and then if you have obstacle within it, you try to avoid them without teaching a new map. But if it cannot pass, then it will not. Then it will just stop.
But in terms of long-term localization, let's say that they got new furniture for the elderly.
Yeah.
Would you need to come there with the tool?
No, that there you don't need to reteach a map or so for new furniture and things in the way. So the robot calculates the way by itself and also can avoid new obstacles which are in the map. So you don't need to do it again. But maybe we can have a conversation afterwards.
I think I was just going to suggest that I think that calls for a deeper conversation indeed. Okay, another question over there, please.
Excuse me? Aha, okay. So my sales guy would say, don't say any number, but it's about 80K, the robot. And with integration, you end up at the 110, 120. There are also different models that you can have first a project, 6 months to integrate it, because we have people who accompany the facility with implementation, workshop, etc. And then you can rent or buy after 6 months.
Yes, please. And then afterwards, more trivial question, and I have to say, since you mentioned that also the form of the robot has a meaning or a study behind, I would like to ask if there is also the same case for the color.
The color, yeah. Yes, so we thought what color would be good. So white was too clinical, we thought. Green was too ecological. Red was too alarming. And yellow didn't look well, so we went for orange. So it was just most accepted in the end.
Hi, Lucas. Thanks for the presentation. I see you use ROS, but then you also mentioned MIT.
Yes. Mm-hmm.
Do you do it for a regulatory perspective problem? Do you do it for any other reasons? I mean, why do you basically migrate from ROS to something else? Or maybe you do them other?
Yes, yes. I think we use them in parallel. Just we use some ROS services to connect the different devices in the robot and also access third parties to communicate with the robot. But the whole robot itself is powered by our own operating system, where we just have dedicated functions that we really need and that can be more powerful and specialized on what we need. So it's a combination of these two features. Yeah. But Niels is more capable of explaining the details to you than I am. Yeah. Yeah. Mm.
Right, another question there from Susanna.
So the robot can work 16 hours a day and charge them 4 times 2 hours or 2 times 4 hours. Depends on how active the robot needs to be in terms of traveling distances and things like that. Yeah.
Okay, thank you very much. That's great, wonderful. Okay, just stay there. We are just saying goodbye to our online audience because we have a couple of things that are only concerned for the people in the room. So thank you for watching us, and we also record it and we make it available afterwards. Have a nice evening. And again, thank you for being with us, and we're saying goodbye now. Bye-bye.